So here phosphorylation of vesicular proteins occur, in which we have certain pores, and these pores are called as aquaporins. These are the vesicular proteins having pores. Okay, now these vesicular proteins along with the aquaporins will go to this membrane and will attach here in this way. These are the aquaporins. Let's 3 in number here, and vesicular protein attach here in this way with the membrane. Okay, so what will this cause? Now here we are seeing that pores are produced in this. Now what will happen? Water will start moving in this cell. Same case for all the cell. Water is going to start here from the limule of the collecting duct into these cells. These cell have on this side, basal side, also pores which are open all the time. No need of antidiuretic hormone. So water start going from this, passing throughout the cell and moving toward this direction into this region, and blood volume increases. So this is the mechanism of action of antidiuretic hormone on the collecting duct or the distal convoluted tubule, in which antidiuretic hormone increase the water level of the blood. Another function of the antidiuretic hormone is the acting as vasopressin. ADH as a vasopressin. So in this case, antidiuretic hormone will act on a blood vessel. ADH will act on smooth muscles of blood vessels. Okay, so as a vasopressin, antidiuretic hormone act on the smooth muscles of a blood vessel, and it causes the vasoconstriction. Act on smooth muscle and cause vasoconstriction. For example, this is a blood vessel. ADH act on this blood vessel and result in the constriction of the blood vessel. Blood vessel will appear like this. This is functional diagram. Let's now discuss what is the mechanism of action of antidiuretic hormone on the contraction of the vasoconstriction. How antidiuretic hormone act as a vasoconstrictor. Now I am going to draw a cell of a smooth muscle of a blood vessel. This is a cell of a smooth muscle of the blood vessel. This is blood vessel which is carrying antidiuretic hormone. Another blood vessel. This bring ADH, and this ADH act on the receptor which are called as V1 receptor. This is receptor which is called as a V1 receptor. So ADH act on this receptor and activate this receptor. This receptor activates GQ protein. GQ GQ protein. GQ protein activates phospholipase C. Phospholipase C. V1 receptor activates GQ protein. GQ protein activates phospholipase C. Okay, and phospholipase C act on a phosphatidyl ionoside tol diphosphate. Phosphatidyl ionoside tol diphosphate. This is phosphatidyl ionositol diphosphate, and it convert phosphatidyl ionositol dicyto into diphosphate is converted into IP3 and also diacyl glycerol. Okay, this is we have phosphatidyl ionositol diphosphate, which is acted upon by phospholipase C, and it is converted into IP3 and diacyl glycerol. Now this IP3 act upon endoplasmic reticulum. Endoplasmic reticulum of the blood vessel smooth muscle cell have a receptor. This is let's endoplasmic reticulum. This endoplasmic reticulum has a IP3 receptor. Okay, this IP3 receptor are activated by this IP3. Whenever this IP3 receptors are activated, endoplasmic reticulum releases calcium ion. So, whenever IP3 activate IP3 receptor on the endoplasmic reticulum, calcium ion will be released into the cytosol. And now we should know the mechanism how calcium ion cause the constriction of the muscle. So here ADH cause the release of calcium ion by endoplasmic reticulum by this mechanism. Now we should know how calcium ion cause the muscular contraction. So in this way, contraction of the smooth muscle of the blood vessel occurs. So this is the mechanism of a second function of antidiuretic hormone. Here we should call antidiuretic hormone as a vasopressin, because here it causes vasoconstriction. Now in which condition ADH is released, we will discuss. Release of ADH in different conditions. There are many conditions in which ADH is released. Number one is H2O deprivation. Whenever there is a decreased amount of water in the blood, then antidiuretic hormone is produced. The mechanism we have discussed before. Whenever antidiuretic hormone is released, antidiuretic hormone go to the kidney and cause the mechanism which we just discussed. What happened? It causes the release of or reabsorption of blood water from the nephron into the blood vessel of the kidney. Thus, the water level of the blood increases and the problem is solved. Another condition is polydipsia. Actually, what is polydipsia? In this case, ADH secretion is not increased, because in this case we take a lot of water. So when we take a lot of water, water level in the blood increases, so the level of release of ADH decreases. So in case of polydipsia, here I wrote in this case, but this is not the condition in which ADH is released. I just write it. So in this case, ADH secretion is decreased because we take a lot of water and we have a lot of water in our blood plasma. Another thing, really such a thing in which ADH is released is a circulatory shock. Circulatory shock may occur due to hemorrhage in a trauma or any other condition in which we have a lot of blood loss from our circulatory system. So blood pressure decreases, blood volume decreases. So we need to increase the blood volume. For this purpose, we activate the release of antidiuretic hormone, which go from posterior pituitary through the blood vessel to the kidney and cause the reabsorption of water from the kidney into the blood vessel, and thus maintain and try to maintain the level of blood volume. Another thing is cranial diabetes insipidus. Cranial diabetes insipidus. Diabetes insipidus. In diabetes insipidus, damage occurred to the supraoptic nucleus. Supraoptic nucleus is damaged. Thus, release of ADH is decreased too much or no ADH is produced. However, paraventricular nucleus may produce some antidiuretic hormone. So what happened that in the distal convolutional or the collecting duct we have no ADH acting here, thus reabsorption of water do not take place. Okay, so this is the cranial diabetes insipidus. Okay, and what will be the result of this? That dilute urine will be produced. It may occur due to infection or trauma or to supraoptic nucleus. Okay, so cranial diabetes insipidus is a condition. Another condition is a nephrogenic. Cranial mean related to the brain, nephro mean related to the kidney. In this case, however, ADH is produced, but there is a problem in the kidney. So, kidney problem is such that the reabsorption of water do not or cannot take place. Okay, so in this case, problem is not with the cranial system, problem is not with the supraoptic nucleus, but the problem is with the reabsorption of water. There occur any problem at the level of kidney, at the level of mechanism that we discussed, ADH action on the distal convoluted tubule and the collecting duct. So any problem which occur there, there will be nephrogenic diabetes insipidus, water reabsorption from the limune of the collecting duct or distal convoluted tubule not taking place into the. So what will happen that dilute urine will be produced. What is Desmopracine? What is Desmopracine? It is man-made form of Vasopressin. This is man-made form of Vasopressin. So let's take a condition how to differentiate a patient of a cranial diabetes insipidus and a nephrogenic diabetes insipidus. We use Desmopracine, ADH functioning molecule. This Desmopracine will act like an antidiuretic hormone. Now, if a patient use Desmopracine and we see that condition come to the normal level. Normally in the diabetes insipidus we have diluted urine, okay, but if we use Desmopracine and urine dilution decreases, urine slightly become concentrated, it means that desmopracine is going to act somewhere. Okay. What does this mean that antidiuretic hormone is not produced in the ADH? Because here nephron is normal. Because if desmopracine is present, normal reabsorption will take place. So if we see that by using desmopracine, the condition of diabetes insipidus come to the normal, urine slightly become concentrated, we will see the problem is with the release of antidiuretic hormone, and this is a cranial diabetes insipidus. Now we have another patient. We do not know whether it is a cranial diabetes insipidus, or this patient is a nephrogenic diabetes insipidus. We use desmopracine in this patient. Now, if by using desmopracine we do not see any change, any concentration increase in the urine, we will think that problem is at the level of reabsorption of the water in the kidney. So we will say this is a nephrogenic, because here ADH is already present. By using desmopracine, there is no effect on the body. We will say there is a problem in the reabsorption of the water. So this is the something to differentiate between a patient of a cranial and nephrogenic diabetes insipidus. So these are something in which ADH is produced. Okay. Now we will take some condition in which increase ADH occur and factors in which decrease anti-H secretion occur. Okay. If the blood osmolarity is high, antidiuretic hormone is released, which increase the volume of water to be increased in the blood, which increase blood volume of the water. Water will increase in the blood. Osmolarity will decrease. If we have decreased blood volume, ADH is released, which increase the blood volume. If we have hypoxia, ADH is released. If we have nausea, vomiting, ADH is released. If we have decreased plasma osmolarity or blood osmolarity, then ADH secretion is decreased, because we have already a lot of water in the blood. If we have high blood pressure, same condition, ADH decrease alcohol and increase blood volume also cause to decrease the release of ADH. So this is something about posterior pituitary. Okay.